Today we are going to talk about with you blood pressure. Blood pressure, which is part of hemodynamics. We are going to see how blood flow is guided within the body from the heart. How does it go into systemic circulation? Then how does it come back into the heart? And the flow of blood, as we know, it is guided by the pressure difference, whereby blood flows from region of high pressure to region of low pressure. So in our topic, we are looking at blood pressure being the force exerted by blood on the blood vessels, on the blood vessel walls. So the hydrostatic force, this is the hydrostatic force. So the hydrostatic force exerted as blood is moving via the blood vessels, it exerts the force, or there is a friction between the blood moving and the walls of the blood vessel. And that force exerted is what we are calling blood pressure. And this blood pressure is categorized into two, whereby we always have systolic pressure and diastolic pressure, whereby systolic pressure is the force created during ventricular systole. So this one is created during ventricular systole or ventricular contraction. So especially when the left ventricle contracts after blood filling, this during the maximum contraction of these ventricles is the one that is recorded as systolic blood pressure. Whereas diastolic blood pressure is the pressure recorded during complete ventricular relaxation. After the ventricles has pumped out blood to the systemic saturation, they relax. And this pressure, which is recorded when the ventricles are at a relaxed state, maximum relaxed state, is what we are calling the diastolic blood pressure. And the diastolic blood pressure is always between 70 to 80 millimeters of mercury. That is the normal one, or sometimes can go up to 90. Then for systolic is between 110 to 120 millimeters of mercury. This is their normal pressure. The systolic versus diastolic pressure. And this pressure is determined by many things. So we are going to see that the blood pressure is affected or determined by three circumstances. One is cardiac output. Then it is also influenced by blood volume. Then lastly, it is also influenced by systemic vascular resistance, or what you can call total peripheral resistance. So these are the three factors that determine the pressure of an individual. That is cardiac output, blood volume, and total peripheral resistance. And we are going to see how this come about to control or to determine the blood pressure of an individual. We're going to start with cardiac output, because we know that blood pressure is equal to cardiac output times resistance, times total peripheral resistance, whereby cardiac output is equal to stroke volume times heart rate. So we are going to see the relationship between stroke volume, between heart rate, whereby the stroke volume is the fraction of blood ejected from the left ventricle in one beat or one cycle. So one beat, we see that the heart ejects 70 mL of blood. That is per beat. Whereas the heart rate, when at rest, the average is always 72 beats per minute. Therefore, the minute pressure or the minute volume is equal to 70 times 72, which is equal to 5 liters. So in a minute, this is per minute. In a minute, our heart is able to pump 5 liters of blood, which we know as cardiac output. So the cardiac output of the normal individual blood is always 5 liters per minute. So we are going to see that how does stroke volume, heart rate, and peripheral resistance affect the blood pressure. But before we go to the effect of them, there is another term which we use, which we call mean arterial pressure. Mean arterial pressure, which is equal to the diastolic blood pressure plus a third of systolic blood pressure minus diastolic blood pressure. For example, if we say that the systolic pressure is 110 millimeters of mercury and the systolic is 70 millimeters of mercury, we are going to see that the mean arterial pressure is equal to 70 plus a third of 110 minus 70, which we can get like at 83 millimeters of mercury. So this one becomes the mean arterial pressure, whereby we are saying mean arterial pressure is equal to diastolic blood pressure plus a third of the difference between the systolic minus diastolic blood pressure. Then we shall also see the pulse rate, whereby the pulse rate also is determined also during blood pressure determination. So let us look at the factors which affect blood pressure in an individual. Exception of the environmental factors and pathological factors, whereby the factors can be age, sex, then exercise, meals, after meals, then temperature. All these can affect the pressure. Then pathological conditions are also there which determine the pressure of an individual, whereby we shall tell you that children have lower cardiac output because their blood is little. Then in sex, females have high. Females, for them, they have also lower cardiac output. Then during exercise, the blood pressure increases. After meals, then when there is a drastic increase in temperature by like 30 degrees, still we see an increase in temperature, increase in pressure. Even altitude determines altitude and so many other factors. But for us, we are interested in these ones, these three. Blood pressure being affected by cardiac output, together with blood volume, together with total peripheral resistance. So we're going to see how these ones are affected within the body. And as blood is pumped, because in the left ventricles we have oxygenated blood, this oxygenated blood is pumped or is ejected. And per beat we have said that the stroke volume is equal to 70 mL per beat. So this stroke volume, the amount of the stroke volume released by during systolic contraction of the heart depends on many factors. So we're going to see that stroke volume depends on many factors such as the preload. Then we are going to see contractility of the cardiac muscles and the afterload. So these ones determine the stroke volume, because stroke volume can increase even up to 100 and something. So how does it increase and when does it decrease? So what determines it is the preload. Preload is the stretchability of the ventricles during relaxation. We are going to see that as blood is pumped, it moves via the arteries, then it goes into arterioles. This is arteries. Then this is the aorta. From the aorta, it joins arteries, then into arterioles, which reaches the capillary bed. Then it comes via the venules, then to the veins, whereby we have the inferior and posterior vena cava, superior vena cava. Then it enters into the vena cava, then it comes back and it is filled during relaxation to the ventricles. So the preload, the amount of blood that is coming during relaxation will determine the amount of blood that is ejected during stroke volume. So one of the factors that affect is preload, whereby preload we are looking at it is determined by the stretching of the ventricles and the duration of relaxation, or duration of filling of the venous blood, which works under Starling's law, Frank Starling's law, which says that the amount of the preload, the more the venous return of the blood, the more the ejection or the stroke volume. So that is one, the preload. Then contractility, which is increased by high levels of calcium, because we know that calcium increases the contractility. Then also the actions of sympathetic nervous system via beta-1 receptors also are able to cause depolarization of the SUN and AVN, which spreads the impulses all over the cardiac muscles, leading to contractions. And when you increase contractility, you increase the heart rate, and still you increase the stroke volume. Then the last one is the afterload. This afterload, before this blood is pumped from the aorta into the blood into the arteries and other parts, we are going to see that there is the pressure in the ventricles. The blood pressure in the ventricles must exceed the pressure in the pulmonary trunk and the aorta. So when this pressure exceeds, that's when blood is able to be pumped into the aorta and into the ventricles. So this afterload also affects, whereby we're saying decrease in the afterload increases the stroke volume, whereas increase in the preload and contractility increases the stroke volume. So preload and contractility, they are directly proportional to stroke volume, whereas afterload is inversely proportional. So these are the three factors we can talk about. And this afterload is always influenced by total peripheral resistance, or what we can call systemic vesicular resistance. So this one is also affected by total peripheral resistance, or which you can call systemic vesicular resistance. How? We are going to say that as blood is moving from the aorta into the arteries, into the arterioles, then capillary, venous, vein, and returns back to the heart, it is facing resistance or the friction, whereby this total peripheral resistance is the total resistance faced by blood as it is moving from arteries to the venous, to the capillaries, then to the veins, venous, then to the vein. And we know as blood is moving it moves from region of high pressure to low pressure. So pressure in the arteries being higher than pressure in the veins, blood is able to flow to the venules. And even the pressure in the venules being higher than in the capillaries, blood is able to reach capillaries. Then by the time we reach at the venules, the venues, it has already reduced like to 16 millimeters of mercury. Here it is in the arterioles, it is at 35 millimeters of mercury. Here it is still like at 70. Then by the time we go to the veins, returning back to the venues, it has gone at 0. So pressure keeps on reducing as blood is flowing away from the aorta to the rest parts of the body. So we are going to see that they face resistance. And this total peripheral resistance, which is the force exerted by the walls, the friction, as blood is moving via the blood vessels, it is facing friction from the walls of these vessels. Those are the aorta, arteries, arterioles, capillaries, veins, and so forth. So that total resistance affects the afterload. And what determines the total peripheral resistance is the diameter size. The diameter size of the blood vessel. It can also be affected by the blood viscosity. Blood viscosity. Then lastly, what affects the total peripheral resistance is the length, the total length of the blood vessel. So these are the three factors which determines total peripheral resistance as blood is flowing. So we are seeing that diameter size, when the vessel, this one is directly proportional, is inversely proportional, whereby if the vessel size, if the diameter size is small, then the pressure is high. So this is inversely proportional. The smaller the diameter size of the blood vessel, the higher the resistance. So when the diameter is small, we see resistance being high. Then with the blood viscosity, as seen maybe in dehydration and polycythemia, that is increased total RBC count. So increase the total red cell count, or during dehydration, where the ratio of blood cells is higher than the ratio of plasma, the blood becomes viscous. And when the blood is viscous, so the more it is viscous, then the more the resistance. So it is directly proportional. Highly viscous blood faces more resistance than less viscous or fluid blood, like during anemia, when the red cells are few. Then the total length of the blood vessel. The longer the blood vessel, the smaller. So when the blood vessel is long, we're going to see that when the blood vessel is very long, also the resistance is also high. And this one explains why obese people, or those obese patients, tend to have high blood pressure because of extra arteries supplying the adipose tissue, and they end up having hypertension. So the longer the blood vessel, the stronger or the higher the resistance. Then highly viscous blood faces more resistance, and the diameter of the vessel, the higher the resistance. When the size is small, resistance is high. When the size is big, resistance is small. So we are seeing size, the smaller the size, the higher the resistance. The larger the size, then the smaller, so it is inversely proportional. So these are the three factors that affect total peripheral resistance as blood is moving via the blood vessels, that is the arteries, veins, and the capillaries. That is what we can talk about. After discussing the stroke volume, there is another concept of heart rate. Because we say the blood pressure is equal to cardiac output, whereby cardiac output is stroke volume times the heart rate. So if I increase the stroke volume, I can easily increase pressure. If I increase the heart rate, I can also increase pressure. So we have seen factors that can increase pressure or reduce pressure when modulated. Then what about heart rate? This heart rate, for it depends on two factors. It depends on sympathetic stimulation due to production of the norepinephrine, which works via beta-1 receptors. Then another factor is production of epinephrine and norepinephrine from adrenal medulla. So all these two factors influence the heart rate. We said the average heart rate is 72 beats per minute, but it can depend on the sympathetic stimulation and epinephrine and norepinephrine, so that when there is increase in sympathetic outflow, the heart rate increases. If there is increase in production of catecholamines from adrenal medulla, still the blood pressure, the heart rate increases. And if there is a decrease in parasympathetic outflow due to production of acetylcholine, which works via M2 receptors, which are G inhibitor, meaning they inhibit contractility, hence decreasing heart rate. So if stimulation is high, heart rate increases, heart rate reduces, and when it is low, heart rate increases. So low sympathetic stimulation, high sympathetic stimulation, high catecholamine release from adrenal medulla, and low sympathetic stimulation work hand in hand to increase heart rate. So those are the factors that can affect heart rate. As we are moving on, there is another concept which we have not talked about here on the preload, which we said this preload, apart from stretching and duration of the ventricular filling, also the venous return affects. We said the venous return affects the preload. The more the blood which is coming via the veins into the vena cava and the right ventricle, the more the preload. And the preload or the venous return, which we are seeing, is also affected by many factors, like skeletal muscle pump, respiratory pump, then venoconstriction. So as the blood is returning, deoxygenated blood, it is also determined by the venoconstriction. Venoconstriction is determined by the respiratory pump, then the skeletal pump. All these factors, they also affect the venous return. So after seeing this concept, in summary, we are going to see that increase in stroke volume versus heart rate, all of them are going to work hand in hand to increase blood pressure. But also don't forget that the blood volume increases together with total peripheral resistance. So we are seeing that blood pressure, which is affected by stroke volume times heart rate times total peripheral resistance. Which one we have said this one is cardiac output. So we have seen the factors that affect stroke volume, which can contribute to either being 5 liters or more. We have seen those that affect heart rate, which is sympathetic stimulation, epinephrine release, and decrease in parasympathetic, which affects the heart rate. That one we have also covered it. We have seen also factors that determine total peripheral resistance, diameter size of the blood vessel, blood viscosity, and total length of the blood vessel. Also those ones determine total peripheral resistance. And if these factors are stimulated, all of them work hand in hand to increase blood pressure, or what you can call mean arterial pressure, that is MAP, which we saw that MAP is equal to diastolic blood pressure plus a third of the difference between systolic and diastolic blood pressure. So this is what we can discuss with you. But one thing we want you to remember is that for the blood to flow in the whole body, it must be moving. The factors which determine is the pressure concentration gradient. It moves from regions of higher pressure to regions of low pressure. And another thing that affects is the total peripheral resistance and also compliance, the expansibility of the blood vessels. So we are seeing pressure gradient from higher to lower, then plus compliance, ability of the blood vessels to expand when the blood is moving through, because blood vessels are elastic. So the more they comply, the more they distend, the pressure that the blood is able to move, which also can determine the resistance. So this is what we can discuss with you in this session, where we are looking at blood pressure and the factors that affect blood pressure. Thank you so much for learning with us at Medical Sciences. We are always privileged to serve you at the comfort of your home, at your workplace. Always keep tuned to keep learning more. More videos are still awaiting. Remember to subscribe, like, and share to many others. Thank you so much.